The advertising messages in this episode are brought to you by Breast Cancer Index, the first and only test recognized by professional oncology guidelines to predict benefit from extended endocrine therapy in early-stage hormone receptor-positive breast cancer. Can you identify the 95% of women who don't benefit from extending anti-estrogen therapy from 5 to 10 years? Breast Cancer Index can help. To learn more, visit breastcancerindex.com/ONS. You're listening to the Oncology Nursing Podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Stephanie Jardine, Oncology Clinical Specialist at ONS, and today we are joined by Marlo Esch, Breast Care Nurse Navigator at Froedtert and the Medical College of Wisconsin in Milwaukee, and member of the Southeastern Wisconsin ONS chapter, to discuss how nurses can talk to their patients about sex and the strategies for overcoming awkwardness. You can also earn free NCPD contact hours by completing the evaluation we've linked in the episode notes. Thanks for joining me today, Marlo.
Absolutely. It's wonderful to be here.
This is a topic that a lot of nurses sometimes struggle with their patients. And so it's always a topic of interest, I think, and also helpful for new nurses. And we do have a lot of new nurses that listen to our podcast. So I think this is going to be very valuable to our listeners. So to start us off, let's define sexual health and how it fits into patient-centered care.
Of course. So I always like to begin my conversations on this topic by clarifying some of the terms that we commonly hear with sexual health. And so when we think about sexuality, I think the first thing that often comes to mind for people are the reproductive components and the sexual functioning components of sexuality. So our body's physical sexual response, tends to be at the forefront of people's minds. But sexuality definitely encompasses much more than that. Sexual self-concept is important, and that includes how we see ourselves, our sexual identity, how we feel about ourselves as sexual people, and then our sexual relationships, or the role that intimacy, attachment, love, play in our lives. And all of these different aspects of sexuality develop, change over time throughout our lifespan. They're influenced by cultural norms, our relationships, and our personal experiences, including cancer, right? So the term sexual health encompasses all of this. According to the World Health Organization, sexual health is the state of physical, mental, and social well-being related to sexuality. So I think this is really relevant and really important to patient-centered care because cancer diagnosis does not somehow suddenly erase the sexual part of being a human, right? Sexual expression continues to be important in people's lives, important part of pleasure, connection during illness and disease. So there are more and more survivors. The oncology survivorship population is growing because we're getting better at detecting and treating cancers, which means that these survivorship issues are really important for patients.
As you were talking and giving that explanation, which I think is really an important and great way to look at this, we as nurses were thinking about the cancer journey that a patient has and all the things that patients have to think about when they get that diagnosis. And like you said, getting a cancer diagnosis doesn't erase this part of that patient. And it's so important to make sure that we're thinking about the whole patient and all aspects of who they are and how we incorporate all of those different aspects into their care and keep that into consideration.
Yes, absolutely.
So what are some of the ways that common treatments for cancer, so many patients, they get surgery or they have radiation, chemotherapy, endocrine therapy. There's just so many different therapies that they are going to probably experience during their cancer journey. But how does that affect a patient's sexual functioning and intimate relationships?
So you're right. All different kinds of cancer treatment modalities have the potential, not only how people's bodies physically function, but also, their body image, their self-confidence, their relationships. And most of the sexual problems that survivors face are related to the treatments rather than the cancer itself. So when we think of common side effects of treatments that can contribute to sexual challenges, some of the first things that come to mind are the changes to the reproductive anatomy and function, right? So structural changes to the genitals, anatomical changes to the length of the penis for prostate cancer, as an example, changes to the vaginal canal, shortening vaginal tissue, challenges, scarring, stenosis, things like that, structurally. And then physiologically, sexual response can be impacted as well. So pelvic surgery, pelvic radiation can damage nerves and blood vessels that supply sexual organs and are responsible for the physiological sexual response in the genitals. And damaged nerves can lead to changes in orgasm, reflex, and sensation. But in addition to that, you mentioned endocrine treatment, right? So there are alterations and interruptions in sex hormone production for a lot of different cancer survivors regarding those treatments. So endocrine therapy is certainly one, but surgery, radiation to the brain that can impact the hypothalamus and pituitary gland can alter sex hormone production. Surgically removing the gonads, of course, as well, can do the same thing. So I think those are some of the more obvious components when we think about some of the ways that treatment can impact sexuality, but there's a whole host of things that are a little bit less obvious, but can still have a big impact, things like fatigue, loss of energy, mobility issues, pain, altered sensation, like the numbness and neuropathies that can come with chemo and other treatments. The genitals can be impacted by neuropathies, which we don't often talk about. Mucosal toxicities. I think we're good talking about oral mucositis, but we're not very good at explaining that the mucosal tissues of other areas of our body can be impacted, vaginal, rectal tissues and things like that. GVHD, graft versus host disease, can potentially impact the genital tract. So there's just a lot of things that patients can experience from different treatments and that can alter how they relate to themselves and their partners sexually.
So now that we've talked about the treatments for cancer and how that can affect a patient, what are some of the common sexual challenges that patients with cancer and cancer survivors experience?
So, we know that rates of sexual problems, they can vary by disease and treatment modality, time from diagnosis and things like that. But when you look at the estimated prevalence rates of sexual challenges across cancer types, it's pretty safe to say that no matter what oncology population you're working with, you're likely to encounter patients on a daily or a weekly basis who are either currently struggling with a sexual concern or might be at risk or might encounter a sexual concern sometime in the future. So some of the more common challenges that are broad ranging for, multiple different types of treatment modalities, as well as disease types, different patient populations. Dyspareunia or pain with sexual activity is the most common sexual complaint in female cancer survivors. And that's often related to vulvovaginal tissue changes from estrogen loss, or potentially the vaginal stenosis and scar tissue that can occur with surgery, radiation. Sometimes pelvic floor muscles function is altered, and that can also contribute to pain or discomfort with intercourse. Erectile difficulties are the most common sexual complaint for male cancer survivors, and that's typically related to the damage to nerves and blood vessels of the genitals from pelvic surgery and radiation. And then, both men and women can experience changes and challenges in desire, libido, or orgasm. Certainly, alterations in body image can be a big factor in the sexuality of patients after cancer. A lot of patients talk about themselves in terms of like this quote unquote damaged goods, right? And that's easy to understand. A lot of the physical changes that occur with treatments, scarring, loss of body parts, hair loss, weight fluctuations, lymphedema, stomas, ostomies, these are all things that can contribute to how we see ourselves and how we feel, how desirable we feel to our partners and things like that. And then in addition to that, of course, relationship challenges maintaining intimacy with partners. There's changes in relationship dynamics. Partners used to be equals, used to be sexual partners, and sometimes there's this change to a caregiver-patient dynamic, and that can be difficult to navigate, right? Changes to the sexual routine. Sometimes what used to work is no longer possible or has different impacts, and it can be a struggle to navigate that as well. And people who are unpartnered during treatment or after treatment and who are looking to begin dating can be really distressed about disclosing some of the body changes and what they've been through. So it's really global impacts that we're talking about kind of from all angles here.
So many challenges that they have to endure. We think that the diagnosis alone is going to be hard enough, but as you've mentioned, so many different changes in their body that they're going to have to kind of learn how to move forward with and how to manage, I would say. And speaking of how you manage those things, what would be some evidence-based recommendations to be able to give those patients for managing those challenges?
So this is an area where more research is always going to be helpful in guiding effective care for patients, right? But in general, we tend to endorse the biopsychosocial approach as typically the most effective. And basically what that means is we're addressing both the physiological symptoms or concerns, functional challenges and things like that, but then also addressing some of the more cognitive, emotional, and relationship contributing factors as well. So, for pain, for persons with vulvas and vaginas who are experiencing dyspareunia, if it's related to estrogen loss, vaginal dryness, vaginal moisturizers for maintenance can be really helpful, as well as use of personal lubricants, what I call lubricants for lovin', right? So that's typically the first line treatment. Some survivors are eligible for like topical hormone treatments and things like that. That does kind of depend on the type of cancer that you've had and specific components. So that's certainly a conversation to have with providers. But vaginal dilator therapy, different types of sexual aids, recommending different types of positions can also be helpful for discomfort, especially related to vaginal stenosis and scar tissue. The American Cancer Society has some awesome information actually on sexual positions. So check that out if you're interested. But pelvic floor physical therapy is a really important opportunity to help women with sexual pain, especially related to muscle spasm and things like that as well. Erectile difficulties, of course, there are pharmacological aids, oral medications, injections. There are mechanical aids that are available. An interesting education point that I think is really important to point out to a lot of people who are experiencing erectile difficulties is that they can actually have an orgasm without an erection, and that's not often known. And so I think that's just one example of how education can help people reframe what their sexual encounters look like. So education is really important as well. And I think, for desire, that's a little bit more tricky. It's really common to have desire issues after cancer. Often it's kind of these psychosocial components of education, talking about mindfulness, talking about responsive desire versus spontaneous desire can be really helpful. Reviewing medications, SSRIs, sometimes pain medications can impact orgasm response as well. So just having that conversation, getting that health history can be important. I think for body image issues, helping people with self-compassion, there's Dr. Kristen Neff has done a lot of research on self-compassion, and body compassion is part of that. And I would definitely encourage people to look into that research as an opportunity to kind of help educate patients on non-judgmental acceptance of some of the changes in their bodies. Grieving can totally occur, loss of body parts, loss of precancer self can impact how we feel about our bodies. A lot of times, different types of treatment are really invasive for people. You're getting touched in intimate places by a lot of strangers, and coping mechanisms include disconnecting sometimes as our body is as a source of pleasure. And so, like you mentioned, kind of relearning or rediscovering what our bodies mean to us can be important as well. That new normal, that kind of adjustment period.
So many good suggestions and great information for folks who are listening and, kind of remembering or learning new things that are important for our patients and important ways to help our patients through this time. And we've talked a lot about those challenges and now, how we manage it. But now let's talk a little bit more about the actual patient and the different populations of patients that we may encounter as we're caring for our cancer patients. Are there any of those patient populations that might require special considerations?
Like we talked about in the beginning, sexual health and sexuality is a component of being a human. And so it's important for us to engage in those conversations and acknowledge that with every person that we are providing care to. But some of the special patient populations that can sometimes get left out of the conversation or need some special consideration include the AYA community, adolescent young adult community, just because of their life stage, sexual development stages that they might be going through during cancer treatments, as well as just anticipation of that they are going to be in the survivorship phase of care for a long time. And so some of these more long-term and late effects can really be prominent and important to address for these patients. Older adults, our culture desexualizes people who are sick and who are ill, and it also desexualizes older adults. But sexuality is important through the lifespan, and that's what the research shows. And the same thing for people at end of life. Sex isn't just intercourse, right? It's intimacy, it's connection, it's sensual touch. And sometimes for people in palliative care or at end of life, that is how, that's one of the most beautiful ways they can connect with a partner and find comfort in their lives. And so affording privacy and opportunity for those interactions can be really important in that population. And then the LGBTQ community, individuals who identify as LGBTQ, there's a long history of mistreatment and abuse in these populations from the medical community. And so there's certainly understandably reluctance to disclose status sometimes. So it's just really important to come into these types of conversations without assumptions, without judgment, and with the expectation that everyone deserves to have this component of their life adequately addressed.
Thank you. That's good to really, again, remind us of the things that we need to consider. So how can nurses approach these populations in a safe and inclusive way whenever you're, trying to make sure that you're bringing in a patient's sexual health into the discussion?
I think there's a couple of ways. I think one, whenever you're having conversations about something private, intimate, sensitive, it's a good idea to ask permission first and just, normalize the discussion, but just ask permission if it's okay if you ask a couple of questions about sexual health. I think it's important to ask patients how they want to be addressed and what their pronouns are, how they want certain areas of their body to be referred to. Mirroring how patients refer to themselves and their bodies can be really important. So neutral language too is really important. So referring to anatomy and physiology without gendering it, right? And using the term partner instead of husband or wife or boyfriend or girlfriend can be some important ways to just try and be inclusive and allow patients to feel safe sharing some sensitive information.
The advertising messages in this episode are brought to you by Breast Cancer Index. Joint pain and hot flashes, mood swings and weight gain. Breast cancer patients on anti-estrogen therapy know all about the side effects, which is why the decision of whether to stop therapy at 5 years or to continue through 10 is so vital for so many women. Breast Cancer Index is the guideline-recognized genomic assay for evaluating the duration of anti-estrogen therapy, a modern predictive tool that removes the guesswork, validates decision-making, and improves patient compliance. Breast Cancer Index, the modern guideline for extended endocrine therapy. So nurses are considered one of the most trusted professions. And as we are thinking about all of the different things that we need to teach patients and as we're caring for patients and monitor for and things like that, what is our role in addressing sexual health needs of our patients and survivors?
So we know that survivors report sexual health as an unmet need in survivorship care. So that illustrates that there is a disconnect between what patients are experiencing and what they need and what they're being provided, right? Studies show oncology healthcare professionals, including nurses, even when they report that they understand sexual health is important and is a part of their role, it's not routinely inquired about, very inconsistently, very low rates of actually bringing this into the conversation. So I would say, as a nurse, it is our responsibility to bring it up, open that door, ask questions, general question early and often to give patients an opportunity throughout their treatment, throughout their survivorship to bring issues up as they kind of experience them. Building questions that address sexual health into our routine care, asking everyone legitimizes sexuality as an overall part of health and well-being. It validates these patients as sexual beings. It normalizes any challenges that they might be having, and it gives them permission to talk about it. So bringing it up, number one. Number two, nursing process, right? Like assessing for issues and assessing, what kinds of specific concerns patients have. It can be as easy as screening someone with one or two questions that are really quick. For example, the NCCN, the problem list, if they check that, sexual problems box, acknowledge that, and ask them more about it. The survivorship assessment questions from the NCCN survivorship guidelines, there are two questions that address sexual health. I think one is like, are you experiencing any sexual issues? And the second follow-up question is, are they causing you distress? So just these real quick screening questions to identify patients who are having issues is really important. You can certainly dive a little bit deeper and kind of figure out what kind of symptoms they're having. There are questionnaires, assessment tools for sexual symptoms. The brief sexual symptom checklist for women and the sexual health inventory for men are two examples that are listed in the NCCN survivorship guidelines. One of the things that I learned when I was going through my education through the University of Michigan sexual health program was kind of digging a little deeper with the acronym DOUPE, which is kind of weird, but it's DOUPE, and it just stands for, asking patients to describe what they're experiencing, the onset of their symptoms, what their understanding is, any problem solving that they have tried, and kind of what their expectations are. And I think we do this all the time with all different kinds of symptoms with patients, right? Helping patients identify their problems, clarify their goals, and then creating a nursing plan of care around that, which could be as simple as providing some education and or providing potentially some referrals to some specialty care.
One thing that we haven't talked about is that you are a breast cancer survivor yourself. So I'm sure that your own personal experiences as a patient and survivor have definitely helped you in the way you interact with patients and just even in, as you mentioned, going to the program at the University of Michigan, almost to specialize in this area of sexual health. It's an important topic to you. So, as we've talked about how the nurse is the trusted professional and we have the ability to open that conversation up with our patients, I think it's important now because we mentioned right at the very beginning that this can be awkward for, nurses who haven't ever had this conversation with patients before, or the patients might feel awkward about this, but I think it's important for us to talk about what some of those communication skills might be that will help us as nurses bring this issue to light, make it a open discussion and a safe place for our patients to talk about this with us. So let's talk about what that communication might look like and maybe even do a little role play of what you as a nurse at the bedside or the chair side in the clinic would recommend, or how you would have those conversations with a patient.
All right, so in a busy clinic, sexual issues can sometimes get lost within other priorities, but there are a lot of different communication tools out there that can help aid nurses in kind of remembering the steps in asking patients some of these important questions. And really, it can just take a few minutes. They're all kind of designed to just take a few minutes to be able to screen and assess and make a plan of care for patients that do have some sexual issues. So one of the models that I really like to use is the PLISSIT model. It's PLISSIT, and it stands for permission, providing limited information to patients about their sexual concerns and some specific suggestions. And then the IT stands for intensive therapy. So really, I think of that as any kind of referral for any care that you feel is kind of outside of the nursing scope of practice, or if there's any additional specialized care that you think patients could benefit from.
So how about if we do a little scenario to see how these might work?
That sounds perfect. Let's do it. Okay, Stephanie, there's one more thing that I wanted to touch base with you about today. Because intimacy and sex are important aspects of many people's lives, I always address this component of survivorship with patients that I work with. Would it be okay if I asked you a couple of questions on this topic today?
Sure, I guess.
Great. So I know that sometimes it can be hard for patients and their providers to adjust to sexual changes in their relationship after cancer. So I'm just wondering how things have been going for you since treatment.
Well, not that great, actually. I sort of thought that by this time we would be back to normal, but we're not. It's like my interest in anything sexual has just completely disappeared.
Sure. Well, decreases in sexual desire are pretty common in women who've had treatment for breast cancer. Do you mind sharing a little bit more?
I don't know. My body just feels different. The few times we've tried to have sex, it's been really uncomfortable, like sandpaper down there. It makes it so I'd rather just not try at all.
Okay, well, I do see that you're on tamoxifen and also that you've been receiving Eligard injections to shut down your ovarian function. And as you might know, these treatments work by altering the levels and effects of estrogen in your body. So while they're excellent at reducing your risk of breast cancer recurrence, they do often cause side effects like vaginal dryness and painful intercourse. For a lot of women, these symptoms can be managed pretty well by starting a routine with an over-the-counter vaginal moisturizer, which can help counteract these effects, and it can help maintain the health of the sensitive vulvovaginal tissues. One of the other recommendations I could make would be making sure to use a personal lubricant during any kind of sexual activity or touch, which can help make it more comfortable and more pleasurable. I do have a handout on these recommendations that we can spend a couple of minutes reviewing before you leave today if you'd like.
Sure, if you think that could help.
I do. Perfect. So now I do want to circle back really quick to your concerns about sexual desire. Physical symptoms, changes in hormones can play a role in desire, so that might be a contributing factor for you, but other things can impact desire as well. Sometimes negative thoughts, feelings, worries can kind of get in the way of being interested in or enjoying physical intimacy. Other patients that I've worked with have reported that meeting with our counselor here in the Quality of Life Clinic was really helpful in understanding and working through some of these types of challenges. Would that be something that you're interested in at all?
I don't know. I think I'd rather just hear what you have to say about that vaginal health stuff for right now.
Sure. Okay. Well, I think that sounds like a great place to start. But if at any time you change your mind or you're interested in learning more about meeting with our sexual counselor, just let us know. We can always place a referral for you. But also, I would like to plan on following up with you regarding these concerns the next time we meet, if that sounds okay to you.
Yeah, I think that sounds good. I think it'll be good to talk through a little bit more. Thank you so much.
You're welcome.
Marlo, that was great. I think that is a great way to give nurses the ability to comfortably start those conversations, because it can be awkward, and especially for new nurses who maybe haven't ever had those conversations with patients. So thank you for giving us that and for starting us thinking about what ways we can do that and how important it is for our patients that we are caring for. I just want to thank you. This has been a great conversation, and I think you and I could probably go on for another hour discussing this, and just, your passion and your ease of having these conversations is so evident. But as we're finishing up our interview, I just wanted to ask you a couple questions that I end all of my podcasts with, and we're going to just do those really quick fire. And the first one I'm going to ask you is, what are some misconceptions about the role of sex and the conversations surrounding the topic in patient-centered care?
I think there are a few. One is that the assumption that sex is not a priority or not important to patients, which is absolutely not true. A second misconception that nurses are often worried about is that they're going to offend their patients by bringing up these sensitive issues, and that's also not true. Studies show that patients want to be asked about these issues. They report really appreciating being asked. And, studies also show that patients are comfortable having these conversations with nurses. One of the last misconceptions is, healthcare professionals often feel that patients will bring up the issue if it's important to them, which is not the case. The research also shows that despite sexual distress or sexual challenges, very few patients who are experiencing sexual challenges will actually bring it up. So it's important that we do that for them.
Great. The next question is, what's something about the role of sex in patient-centered care that's not often discussed, but you wish people knew more about?
I think it's just important to understand how common this is, and the fact that it occurs commonly in even populations with non-reproductive related cancers. And I mentioned that a little earlier. I think the other thing is just being able to understand the psychosocial aspects of sexual health and sexual functioning. I think it's easy to address sometimes the more physical effects like vaginal dryness and things like that. And it can be more difficult to have some of those psychosocial conversations, but it's really important. And I also just mentioned, just earlier, that despite being a sensitive issue, people really do want to talk about it.
Great. What additional training or education do oncology nurses need to aid them in having potentially uncomfortable and sensitive conversations with their patients?
I think, nurses often avoid bringing up the topic at all because they don't want to open a can of worms, or they're afraid that they're not going to be able to address a specific question that a patient has. But just the simple understanding that it's our role to bring it up and to help them find resources and refer them to places can help get the ball rolling. But I would say understand your resources, understand the people on your team, the people in your organization that you can turn to who have a special interest in this, understand the patient materials that are available, familiarize yourself with some of the common sexual challenges for the specific populations that you work with, through self-study, literature reviews. Dr. Ann Katz has an awesome book for healthcare professionals, Breaking the Silence on Cancer and Sexuality. It's great. And then if you're interested in kind of specializing or, becoming the expert on your team, there are training programs. Like I said, I went through the University of Michigan Sexual Health Program, which was wonderful. ECHO, Enriching Communication Skills for Health Professionals in Oncofertility, is a web-based training program on AYA, reproductive and sexual health, which is also great. So there are certainly opportunities for self-study and learning how to get those conversations going.
Great. And what are some additional resources, whether it's for patients or providers who want to learn more?
I would say for healthcare professionals, Clinical practice guidelines that are really helpful are the NCCN survivorship guidelines, as well as the American Society of Clinical Oncology, or ASCO, guidelines that were published in 2018 on ways to address sexual problems are really good sources of up-to-date information. There is an organization called the Scientific Network on Female Sexual Health and Cancer, which is an interprofessional network that dedicates itself to the evidence-based advancement of sexual well-being in women and in girls affected by cancer. So that's a really good resource. ASECT, the American Association of Sexuality Educators, Counselors, and Therapists, is a good resource for us to be able to refer patients to and for patients to be able to look up professionals who specialize in sexual health. The North American Menopause Society is great. The National LGBT Cancer Network is great. The Oncology Nursing Society, academic journals have a lot of great information in them. And for patients, I would recommend the American Cancer Society. Any of the other organizations that I mentioned also have wonderful patient resources as well. There's a lot of good stuff out there if you look for it.
Marla, this has been a pleasure to talk with you today, and you have really given us a lot of great information on this topic, and one that I think probably is not talked about a whole lot. Maybe we need to talk about it more. Not maybe. Absolutely, we do.
Yes.
Absolutely. But I just want to thank you for being with me. And do you have any other questions or any other comments for us today?
It's been a pleasure. Anytime I get the chance to talk about this, I am all about it. And like you said, I could probably talk about it for 2 more hours. But knowing that as nurses, we build the trust and rapport with our patients that give us the unique opportunity to help them with life issues. And so I just want to say good luck with getting the conversation going out there.
Thank you so much for joining me today.
Thank you.
The advertising messages in this episode were brought to you by Breast Cancer Index, the only guideline-recognized test for extended endocrine therapy. Go beyond traditional clinico-pathologic factors with the only tool validated to inform decisions about extending anti-estrogen therapy from 5 to 10 years. When 95% don't benefit from extending, 100% of women deserve to know. To learn more, visit breastcancerindex.com/ONS. Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part of this episode by leaving a review on iTunes or wherever you downloaded your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guests and not necessarily ONS.